Hello, everyone. My name is Olivier Ferlatte, and I'm a professor at the University of Montreal and one of the research scientists at the Centre de recherche en santé publique. Bonjour tout le monde, c'est un plaisir de vous accueillir aujourd'hui à cet événement. La séance va se dérouler en anglais, mais vous aurez la chance après de poser vos questions en français à nos invités et on les traduira au besoin. Alors, je vais juste trouver les biographies de nos invités.
Olivier, je pense que tu as le YouTube allumé, alors ça fait un retour.
Je n'ai pas le YouTube allumé, je n'avais pas le retour, Malek.
Ah.
Je me demande si c'est de ton côté, en fait. So, thank you, everyone. Do you hear feedback? No? Yes?
No.
Okay. Okay, thank you. So before we start today, I would like to recognize that that also the CReSP and the University of Montreal are located on Tiohtià:ke, the traditional territory of the Mohawks, also known as Montreal, a land that has long been a place of meetings and exchange for First Nation individuals and communities. So the event that we're hosting today will focus on the health inequity of LGBTQ2S plus individuals. We're hosting this event in conjunction with the International Day Against Homophobia, Biphobia, and Trustphobia that was held earlier this week on Monday on May 17. This day is held every year on May 17 to celebrate the removal of homosexuality from the WHO list of mental health disorders that occur on May 17, 1990. Despite the progress that has been made, much work is still needed locally, nationally, and internationally to reduce stigma, improve the social conditions, and reduce the health inequities of LGBTQ2S populations. Globally, 77 members of the United Nations continue to criminalize homosexuality. In Quebec and in Canada, despite much progress in the past 30 years, health inequities continue to persist among this population, such as mental health, suicide, substance use. And I was struck by statistics in the newspapers this week that stated that 86%, there's been an 86% increase in hate crimes against LGBTQ plus individuals between 2015 and 2019. So we have a lot of work to do in terms of ensuring safe places for LGBTQ plus population and improving the health outcomes of those populations to achieve equities. And this is going to be the focus of our talk. We have 3 billion scholars that are from the new generation of LGBTQ plus scholars across Canada. And I think they will all present on their work and help us reflect about how we can achieve health equity for LGBTQ2S plus population. So we will hear first from all of the 3 speakers, and then we will open up for you, the audience, to share your thoughts, your reflections, but also ask questions. First, we will hear from Dr. Travis Salway. Travis is a good friend of mine and a colleague of mine for many years. He's a social epidemiologist whose research investigates the health of lesbian, gay, bisexual, queer, trans, and two-spirit people. He is an assistant professor of health sciences at Simon Fraser University, a Michael Smith Scholar, and an affiliated researcher with the BC Centre on Disease Control and the Center for Gender and Sexual Health Equity and the Community-Based Research Center. Travis, I'll let you do your talk and I'll introduce the other speakers just before their talk.
Thank you so much for the introduction. I think, Hannah, you were going to go first. Is that right?
I'm more than happy to go first, whatever works for folks.
Okay, if we want Hannah to go first, I'll introduce Hannah first. So Dr. Hannah Kia is an associate professor in the School of Social Work at the University of British Columbia and a research scientist at the Center for Gender and Sexual Health Equity at UBC with Travis. Her current research program of research addresses a variety of issues pertaining to sexual and gender minority populations, including health, aging, and CGM communities, as well as social work and professional practice with sexual and gender minority groups. More recently, she launched a study aimed at examining the constituents of effective social work practices with trans and gender diverse people. Hannah.
Sorry, I was just having trouble unmuting myself. Great. Can folks see the slides? Great.
We sure can.
So thank you so much for having me with you today. It really is an honor to be speaking with you and to be sharing the floor with such a brilliant group of colleagues. My name is Hannah Kia. My pronouns are she and her, and I'm an assistant professor at the UBC School of Social Work. I'm also a settler trans woman of Iranian descent. Before we get started, I did want to take a moment to acknowledge that I am joining you from the traditional, ancestral, and unceded territory of the Musqueam people, and I feel deeply grateful and honored to be speaking with you from this beautiful land. A little bit of an agenda to get us started. I want to begin my part of today's event with first contextualizing the emerging scholarship on trans health, and then kind of extend this conversation further to review with you some critical questions I have for this body of inquiry. Finally, I want to close my part of today's event by reviewing the potential for peer-based responses to some of the inequities we currently see in this literature. So let's begin with some context. When I use the terms transgender and gender diverse, I'm usually referring to folks who either fully or in part don't identify with their sex assigned at birth. Conversely, when I use the terms cis and cisgender, I'm usually describing people who either do identify with their sex assigned at birth or who have never questioned their gender identity in relation to their sex assigned at birth. Now, for the sake of simplicity, today I have collapsed trans and gender diverse people together into one category, but it is really important to remember that there's significant diversity within this very broad umbrella. So this category of trans and gender diverse includes folks who identify as transgender, non-binary, genderqueer, gender fluid, agender, bigender, pangender, and so on. Today, I don't have time to get into definitions for each of these identities, but it is simply critical to remember the vast heterogeneity within this group. So why this focus on trans and gender diverse people? First and foremost, trans people experience staggeringly high levels of exposure to stigma, violence, and discrimination. For example, in the US Transgender Survey, which was a national survey of trans people across the United States, 46% of respondents reported verbal harassment in the 12 months preceding the study, while 47% reported lifetime experiences of sexual assault. In the Trans Pulse Canada study, which was a comparable survey of trans people across Canada, 68% reported verbal harassment in the 5 years preceding the study, while 16% and 26% respectively reported physical and sexual assault in the same time period. Aside from trans people's exposure to stigma, violence, and discrimination, there are also some really prominent inequities that are currently foregrounded in the relevant health literature. For example, trans people potentially have higher rates of cardiovascular disease. We may be much more likely to report suicidal ideation and behavior. So for example, we may be as much as 13 times more likely than cisgender people to report these adverse mental health conditions. And we may be more likely to report mood disorders. Last but not least, trans people do report disproportionate burdens of HIV infection, and this is particularly the case among trans women, as far as we know in the scholarship. So when we look at the review, empirical, and conceptual scholarship, we start seeing some explanations for some of these figures. We start seeing in particular that trans people's profound health inequities may be tied in very intricate ways to this population's exposure to minority stressors, including anti-trans stigma, violence, and discrimination. And similarly, we see that exposure to intersecting systems of oppression, including racism, poverty, settler colonialism, ableism, and others, may produce more prominent and at times distinctive inequities for folks affected by these multiple systems of oppression. So this takes us back to a point I was making earlier about not collapsing trans and gender diverse people into one category, but to really account for the heterogeneity of folks in these groups. Now, today, I don't have a great deal of time to delve into some of the health literature on trans-specific disparities in the context of the life course, but I did very, very briefly want to give you a snapshot of this scholarship because I feel it really nicely concretizes some of the insights I'm trying to share with you today. Just to give you some context, older cisgender, lesbian, gay, and bisexual people we know experience poor physical and mental health outcomes relative to their cisgender heterosexual counterparts. Keeping this context in mind, older trans adults, meaning those ages 50 plus, may be at even higher risk relative to same age cisgender LGB counterparts for poor self-reported physical health, disability, depressive symptomology, and perceived stress. And these inequities may, at least in part, be attributed to differences between trans people and cis LGB older adults in exposure to victimization and stigma. And this scholarship is really critical for a couple of reasons. First and foremost, it really draws our attention to examine the health outcomes of trans people separately, in many cases, from the health outcomes of cisgender sexual minorities, instead of lumping LGBTQ2S plus populations together, because we see some evidence of differences in patterns. The second really critical point to make is that this body of scholarship really starts substantiating this link between trans people's exposure to minority stressors on the one hand and our adverse mental health and physical health outcomes on the other. So why is all of this really important? All of what I'm sharing with you today? I would say the key message here is that inequities in trans health have historically been subject to misconceptions. So a lot of health researchers in this domain have historically attributed the health disparities of trans people primarily to the distress that trans people experience about the incongruence between their gender identity and their sex assigned at birth. And now we're starting to see that the picture is actually much more complicated, that, you know, while trans people do experience distress for a whole host of reasons, that it is primarily our exposure to minority stress that explains many of the disparities we experience. And so given the increasingly substantiated link between exposure to minority stress and health inequity among trans people, I think there are a number of gaps that should be addressed at this point. First and foremost, given that our health inequities don't have maybe as much to do with mental health related distress, we need to go beyond the realm of mental health inequities. We need to begin asking ourselves what other health inequities, particularly those in the area of chronic illness, might be prominent in trans populations. And relatedly, we need to ask ourselves how these other potential health inequities might be tied to our exposure to minority stress. And then kind of building on a point I was trying to drive home earlier, I think we should be asking ourselves how exposure to intersecting systems of oppression heighten the susceptibility of diverse groups of trans and gender diverse people to poor physical and mental health. So we really need to start paying attention to how our exposure to racism, poverty, ableism, and other factors might actually inform many of the health inequities that we experience and report. Now, in all of this, I really want to emphasize the importance of qualitative inquiry as a tool for furthering insight on the context of health inequities affecting trans populations. I've been talking to you about some of the historical misconceptions guiding this field, and I think many of them might be explained by the lack of engagement among some researchers with the lived experiences of trans and gender diverse people. And I think the beauty of qualitative inquiry is that it gives us tools for amplifying the voices of those in these groups as sources of knowledge and theory development, and hopefully catalysts for rigorous research. And so I really think we need to take a really close look at qualitative research as a potential for growing this body of scholarship. Now, I've spent some time reviewing the state of the scholarship very, very briefly because time is limited today. And you may be asking yourself, what are some possible public health interventions? And to address this question very quickly, I just want to share with you the example of peer-based responses as one set of interventions that could be used to mitigate some of the inequities we're currently seeing in the literature. And I want to specifically draw on a scoping review study that some colleagues and myself recently led to explore the role of peer support in mitigating suicide risk among trans populations, because I think this study really substantiates the promise of peer-based interventions. So just to give you a very brief snapshot, we reviewed 34 empirical works that were related to this topical area and that spanned the US, Canada, the UK, Australia, and other jurisdictions. And of course, we did draw on scoping review methodology, which I can speak to more for folks who are interested in the Q&A part of our event. As far as some of the key findings that surfaced in our work, we first noticed that peer-based social support was inconsistently measured and captured in the literature. And yet, despite these limitations in the scholarship, we found that access to social support provided by peers was actually quite significant in attenuating suicide risk. We also specifically found that peer-based social support was highly efficacious in enhancing validation and community connectedness among trans people, and in turn served to buffer the impacts of our exposure to minority stress. So here we not only see a substantiated link between minority stress and adverse health in trans populations, but we also begin seeing a potential way to weaken this link. So I think peer-based responses are really important for us to consider moving forward. I did want to add as a closing point that our study did reveal the importance of both in-person and virtual systems of peer support as being effective in mitigating suicide risk. So what can we take from all of this? I think given the high rates of healthcare avoidance and persistently poor physical and mental health outcomes in trans populations, we really need to begin investigating how we can leverage peer support to begin addressing these challenges. And then I think more importantly, we need to explore the promise of peer-based social support as a vehicle for community organizing, activism, and catalyzing systemic change. So many of our health inequities have to do with the structural conditions under which we're living. And if we think about peer-based social support as a means of community organizing and activism, it's also a way to mitigate some of these structural conditions and hopefully a way for us to live in a world that's better for our health and well-being. With that being said, this brings us to the close of my part of today's talk, and I really look forward to the Q&A part of our event. Thank you so much.
Wonderful, Hannah. Thank you so much. So without further ado, we'll go with Travis, who I already introduced.
Okay. Well, let's see if this works. I was just forced to upgrade my Zoom will not be able to record the contents of your screen until it is quit. That doesn't sound good, does it? What if Sean goes next and I'll be right back? I just upgraded to a new operating system yesterday, and today my computer is full of surprises.
Okay, well, you really don't want to go and do your talk. That is twice, Travis, that you get out of talking. So let me introduce Sean then. So Dr. Sean Hillier is a queer Mi'kmaq scholar from the Kalipu First Nation. He is an assistant professor at the School of Health Policy and Management and special advisor to the Dean on Indigenous Resurgence in the Faculty of Health of York University. He is the chair of the Indigenous Council at York and is co-chair of the Working Group on Anti-Black and Anti-Indigenous Racism in the Faculty of Health. Additionally, Sean is a board member of the Native Canadian Centre of Toronto and the AIDS Committee of Toronto. Sean.
Excellent, thank you for that. Hopefully my screen share will work. Fantastic. Perfect. So, Kwayani, welcome and thank you for having me today. As I was introduced, my name is Sean Hillier. I am a Mi'kmaq scholar. I'm a registered member of the Kalipu First Nation with ancestral roots throughout the island of Newfoundland. I grew up on the southwest coast of the island, but my family stretched through both the island and the coast of Labrador. Today, I will be talking to you about health equity for Two-Spirit and queer Indigenous folks and what that means in promoting health equity. If I can now move slides. So I'll start with a very brief land acknowledgement. So I join you today from Toronto. This area known as Toronto has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It's now home to many First Nation, Inuit, and Métis communities. I acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. So I want to provide you a quick overview and background on some of the issues related to Indigenous queer folk and some of the terminology around this and some of the intersecting issues around identity and health equity and outcomes. So when we talk about the term Two-Spirit as well as queer folks, I really want to put a large caveat on this. So Two-Spirit really kind of became popular after it was coined in 1990, and it may be used by Indigenous people who identify as having both a masculine and a feminine spirit, and is used by some Indigenous folks to describe their sexual, their gender, and or their spiritual identity. It can also be used as an umbrella term. It may encompass same-sex attraction and a wide range and a wide variety of gender variants, including people who might be described in Western culture as belonging to the LGBT community or who have multiple gender identities. Traditionally, in some Indigenous cultures, substantially First Nations cultures that we see throughout Central and Western Canada, Two-Spirit and gender non-conforming people were revered within their communities and given very high ceremonial roles and access to both female and male duties. And that we see upon contact, a lot of documentation being sent back by to the papacy in Rome, as well as to the kings of England and France about coming across savages that they had seen these savage men wearing women's clothing and women performing men's duties, and that this was very explicitly something during colonization that they sought to extinguish and to demise through these people. But I want to note very importantly that many Indigenous people, and specifically Inuit and Métis, along with many First Nations who are members of the LGBT community, but they may not identify with this term. And this actually poses a significant problem as we move forward in some of the data collection that we do see and our ability to really kind of capture some of the health disparities that do take place within the population. And so myself as a First Nations man don't identify as Two-Spirits. I identify as a queer First Nations Indigenous person. And so these intersecting identities can be very complex for Indigenous folks. So to provide some background, I want to start out with really highlighting the concept of intersectionality and how we have to foreground the discussion of indigeneity in this discussion, because Indigenous folks in Canada already experience the most significant health disparities of any identifiable group in this country. And so when we layer on complexities of gender and LGBT identities, we see even greater health disparities and barriers to accessing healthcare and health services. So Two-Spirit, Indigenous, and racialized LGBT populations often face systemic racism, in addition to the homophobia and transphobia when they are out seeking medical and mental health care. And we'll talk about how this creates significant barriers a bit later. But what I really want to focus on is that homophobia, transphobia, and two-spirit phobia are not traditional teachings that we have. These are something that have been inherited as a result of colonial processes that very concretely, through the process of colonization, through residential schools, through the 60 Scoops, through the creation of reserves and other policies, have ingrained the idea of the nuclear family and have removed from our traditional understanding of communal child raising and growth and multiple genders, a very kind of defined heteronormative idea of what it means to be an individual in our society today. And this, with the imposition of Christianity upon Indigenous peoples, has created huge issues of homophobia, transphobia, and two-spirit phobia within our communities that continues to permeate and causes significant violence amongst and between our peoples. That there is a lack of knowledge of health status for this group due to a lack of research in the area. We see significant issues in actually pulling in this data that we need due to the complexity of it, and that there just isn't a significant amount of research taking place within this area. And that typically what we see are general health outcomes for Indigenous peoples or LGBT health statistics, and we really do struggle on that integration. So I'm going to start this with something a little unconventional. So many of you may be aware of Billy Ray Belcourt, who is an assistant professor at the University of British Columbia, a poet, is a queer Cree man. And so he has 3 books out around poems, and this is one of them. And I want to foreground this, and I'm going to discuss it a bit later. So 6 theses on why Native people die. Indigeneity exceeds and is exceeded by gender. He doesn't make language out of the gravel like noise stuck in his throat. Once freed from the bottom of his stomach, desire went on a killing spree. She made a casket out of his guilt. We were a sad story, and I fell in love with the idea of it. She watched a Western and thought the world looked better in black and white. Many of the narratives that are found within Billy Ray's books focus around his queer identity, his connection to the history of colonization and modern day implications of homophobia within Indigenous communities, racism that he experienced from white men, and the value that he placed upon himself. And he overlaid many of the words within his poems around the construction of how colonization is deeply linked to the foundations of our gender and our identities and our sexualities as human beings, that I think is so important for us to think and to talk about and to pull apart. So to provide you an overview of some statistics that are out there, nearly half of Indigenous trans people reported pre-tax incomes under $10,000. We see that Indigenous folks are already when we look at overall education as well as employment income, the lowest in this country. And so when you compare some of the gender and LGBT aspects upon that, we see, again, even greater disparities in comparison to the average population. Both Indigenous and queer youth are disproportionately represented in local and national populations experiencing homelessness, at a substantially greater risk to attempt suicide and to complete it, or to experience extreme violence. In the National Commission Reclaiming Power in Place, the final report on the National Inquiry into Missing and Murdered Indigenous Women and Girls, there was a specific highlight around the fact that Canada has staggering rates of violence against Indigenous women, girls, and two-spirited LGBTQIA peoples. And that while the report was commissioned to initially look at Indigenous women, what they found was that there's a clear underrepresentation and underreporting of missing queer Indigenous folks that meet significant violence as they grow up and as they move out into society. Many times they are forced out of their communities as a result of the colonial process. That two-spirit people are more likely to experience mental health issues such as depression and anxiety, as well as substance abuse such as drug and alcohol, or to use substances such as drug and alcohol as coping mechanisms. And this again results from the lack of ability to deal with the traumas that Indigenous people have been exposed to in positive ways. And so we see again furthered implications around not only are Indigenous people intergenerational trauma real, ongoing trauma is real, but that equally we're layering that in with people who are experiencing homophobia, transphobia, et cetera, within their communities and in broader society. And this is why we see elevated rates and why we also see some of the highest suicide rates in not only Canada within Indigenous populations, but when we look at Inuit people, they have a 10 times the national average suicide rate, which is the highest in the entire Western world. Indigenous peoples make up 10% of all people living with HIV in Canada, while making up less than 5% of the population. And Indigenous peoples are currently the fastest growing demographic of HIV in this country. They also represent a very heavy burden of infectious diseases amongst Indigenous populations, including TB, again, syphilis, gonorrhea, chlamydia, across the board. And we ascribe a lot of this into sex work and other issues that we relate back to drug and alcohol use. And I know that Trevor will talk about this a little bit, but I really want to, there's a narrative that's starting to come out within the queer Indigenous community around labeling residential schools as this idea of conversion therapy, that Indigenous peoples were placed in residential schools and they were stripped away from their community, from their culture, but equally they were also indoctrinated into a heterosexual life. They were told within these religious institutions that if they, were queer, if that they didn't ascribe to gender norms, that they were going to hell, and that they would face the devil one day. And that this is kind of the foundation of what we see a lot of the traumas, in addition to the rampant abuse and sexual abuse that was experienced by many. So when we talk very quickly about accessing care and resilience, so just 2 points here. So one is that we see that Indigenous folks have significant issues in accessing healthcare services. And we look at this in 2 different ways. One is racism within healthcare settings. I don't think it's going to be a surprise to anybody on this call with national headlines that have been made, in the past decade, but even more recently around issues of racism towards Indigenous people when they are entering into healthcare settings. And that these are just a couple of headlines. As soon as I Googled racism against Indigenous people healthcare, there were hundreds and hundreds of hits that came up. Investigation finds widespread racism and discrimination against Indigenous people in BC healthcare system. Fears of racism deter many Indigenous people from seeking medical treatments. Healthcare systems, the healthcare system was designed to subject Indigenous people to systemic racism. These are ongoing colonial processes that interact at that intersectional level that further suppresses queer Indigenous folks from accessing healthcare, because not only are they experiencing racism in accessing that care, but many times they're equally experiencing homophobia, transphobia in those settings, and they're not receiving the type of care that they require. And additionally, there's also just a general lack of access to healthcare. And this is especially true for those that are living in northern and remote communities across this country, in that they certainly already generally lack access, but then they're certainly going to lack competent access from professionals who understand queer health in that same sense. So I'm going to quickly focus on a study that I led, and this was really looking at Indigenous folks who were living with HIV in the province of Ontario, and we came up with a set of recommendations around decolonizing the HIV cascade of care. And so the cascade of care, which focuses attentions on individuals being diagnosed, entering antiretroviral treatment, and then viral suppression is achieved and maintained. The cascade, as it stands today, does not yield positive outcomes for Indigenous peoples living with HIV. So we see the cascade having a significant impact, and we're actually meeting, I think, a fairly good rate at the cascade level for the general population. But when it comes to Indigenous people, we are drastically lagging behind. And so the question is, why is this happening, and what can we do to stop that? And really what we see is that individuals are experiencing barriers at each step of the cascade due to poor service access, due to a lack of HIV education for practitioners, significant stigma and discrimination as both queer folks, but also as Indigenous folks, but compounded upon the colonial aspects of widespread poverty, food insecurity, homelessness, mental health and substance abuse, the quality of education within reserves, housing within reserves, et cetera, all become these structural barriers that impede people from being able to access appropriate levels of care. The recommendations that were found within this paper were rooted within Indigenous voices, and that they seek to address the inequalities faced by Indigenous peoples within living with HIV when seeking confidential testing and diagnosis, as well as sustaining access to antiretroviral treatment and maintaining viral suppression. What we heard over and over again from participants in this study was that the specialists that they were encountering were very violent with them, and that they were rough with them, that they used really inappropriate language, that they were threatened, that they were told, if you're not going to adhere to treatment, that we're not going to see you anymore, that you're better off just dying, etc. That people need not worry about having children because they were living with HIV and they don't want to have more confounding issues within their families. So these are the types of narratives that continue to be pervasive within healthcare settings that prevent and retreat people from accessing healthcare. But I very quickly want to note about the resilience of Indigenous people, that connection to culture and traditions can help protect all First Nations from the risk of suicide. But for two-spirited people, research has told us that this takes on additional meaning, that when people have strong cultural and traditional connections, that this is one of the greatest barriers to suicide, or one of the greatest ways to prevent suicide and suicide ideation. Wilson in 2008 note that two-spirit identity is about circling back to where we belong, reclaiming, reinventing, and redefining our belongings, our roots, our communities, our support systems, and our collective and individual selves. And that this is fundamental in order for us to be able to heal, not only as a people, but as a community, because unless we heal as communities, we'll never be able to accept our traditional teachings and our understandings around queer and gender diverse individuals. We also acknowledge here the note that knowledge of traditional cultural roles and identity has the power to instill positive identity and healthy self-concepts in two spirits. So where do we go from here? The last two slides. So how do we attain health equity? I think there's a four-pronged approach that we see, widely spread across the literature. One is inequity responsive care for Indigenous folks, that we have culturally safe care for Indigenous folks that is also understanding of gender diversity, that we have trauma and violence informed care, and that we have contextually tailored care. And this includes promoting programming by and for Indigenous peoples. Over and over in the studies that are out there, when we look at ways to encourage greater health outcomes for LGBT community members who are Indigenous, but also Indigenous peoples more broadly, it's that they want to see healthcare services being led by them, that is for them. And that we need to see the integration of Indigenous ways of knowing and healing into Western medicine. that there's an increased need to for training or increase access to training and knowledge about Indigenous peoples for healthcare professionals. And this is vital to understand the history and the context of colonization, to understand the health inequalities that exist within our society today. Because the tropes and stereotypes that I continue to hear and we continue to face fundamentally impair our ability to deliver adequate healthcare to folks. And that overall, we need to increase access to healthcare services for Indigenous people. Study after study continues to tell us that Indigenous people want to access healthcare, but that barriers in place prevent them from doing that, and that they actually have a greater interest than the Canadian population at preventative healthcare. And finally, what can you do to help attain health equity? So these are just a couple of things that are here. So focusing on your client's resilience and positive coping skills in the physical, mental, emotional, and spiritual aspects of their lives and in their relationships. And so I've provided here, representation is so important. Having an understanding of what traditional culture from a First Nations perspective, in this case, you're seeing some examples of holistic medicine wheels or medicine circles that include the mind, the heart, the spirit, the body, etc., that go on to really be important to how we understand positive health outcomes. That we have to help in providing access to positive two-spirited services and people that are in alignment with the client's culture and traditions. We have to ensure we're not taking a pan-Indigenous approach to this, that we can't just say, oh, here's an Indigenous approach to all healthcare, but that we have to tailor this to the recognition that my colleagues out West will have a very different approach to understanding health equity for Indigenous people in BC than what we have here in Ontario versus in the Mi'kmaq Nation across the East, but will be very different from Métis health and radically different than Inuit health in the North. And that we have to create positive, affirming resources or safe spaces in the community for two-spirited people. These help young people to develop a positive self-concept and have positive impacts on the health of two-spirited people of all ages. And here, for the first time ever, when I was the chair of World Pride in Toronto in 2014, we had our first ever opening dance by queer two-spirited individuals at our opening ceremonies. And that we heard a lot of feedback from the Indigenous community saying how powerful it was to see ourselves again represented on an international stage. I probably took way more time than I should have, so thank you all so much.
Thank you so much, Sean. This was a wonderful presentation. Thank you so much. And now let's see if we can get Travis to present.
Third time's a charm here. Okay, well, we've made it one step further than last time.
I think it's working.
Excellent.
Perfect.
How does that look?
Perfect.
Okay, good. Well, thank you for your patience, and thank you so much, Hannah and Sean, for your talks. I learn so much every time I hear you speak, and I really feel honored to be able to share the Zoom stage with you. And thank you, Olivier, for the invitation and for the very kind introduction earlier. My name is Travis Salway. I use he, him pronouns, and I am an assistant professor at Simon Fraser University. And as with Hannah, I am also joining from Coast Salish territories, where I humbly want to acknowledge that I am an uninvited guest. These images on the left are of Luk-Luk-Waitin, which is a Squamish word, place name for Burnaby Mountain. That means the peeling bark. It's a reference to the arbutus tree. And this is the place name for where Simon Fraser University is situated. And on the right is the Vancouver Aboriginal Friendship Center, which is just across the street from where I live in East Vancouver. I'm feeling very appreciative to the services they continue to offer throughout the pandemic. Sean already did a beautiful introduction about the organizing term two-spirit and the acknowledgement that diverse sexualities and genders predated colonization, predated the arrival of Europeans, and the loss of those are a direct effect of colonization. And I'll just add that one of my colleagues here has recently put out some recommendations, Harlan Pruden, with the support of the CIHR Institute of Gender and Health. And this is just our proposal for those of you who are thinking about incorporating two-spirit measures in surveys. We've put together some methods to explain how we took a survey where we previously presented two-spirit alongside Western sexual identities and have now actually changed how it's presented in our surveys to make sure it's clearly signaling its rightful meaning for Indigenous peoples. So I'm an epidemiologist, which means I like to count things. And this is my current count of where we're at for the population we're discussing today. So lesbian, gay, bisexual, queer people, or people who have a minority sexual orientation constitute somewhere between 4 and 8% of the general population. This depends on what definition of sexual orientation you're using. And as Hannah already explained, the trans people, which is often used as an umbrella term for gender minorities inclusively, which includes people whose gender identity differs from sex assigned at birth, are estimated to be around 1%, perhaps up to 3% of the population. Now, why are these numbers, why are these ranges so big? Well, these estimates change year by year, and that's because thankfully we are seeing increased visibility and increased access for young people and adults to their identities as queer and trans and two-spirit people. So this is kind of how I frame my thinking about the topic. We have a minority population that's growing, and that has a lot to teach us about sexual and gender diversity. So I really appreciated that in the introduction to this panel, Olivier, pointed out that we have some really contradicting trends going on in Canada at the moment. This is the message that our government would like to send to the world, which is that we are an equal and safe country for LGBTQ2 people. And these are some of the milestones that are often held up as points of pride for us as Canadians. And of course, these are significant achievements. We have seen remarkable progress when it comes to legal rights for LGBTQ2 Canadians. But we do have to somehow square up this notion of contemporary equality with the epidemiology of sexual and gender minority health. So these are data that my colleagues and I have been meta-analyzing over the last few years. This project is led by Dr. Laurie Ross from the University of Toronto, and we've pooled hundreds of surveys from sexual minorities. So this is referring to folks defined based on their sexual orientation, specifically lesbian, gay, and bisexual adults and adolescents. And what we see is a striking and persistent disparity across time and place, where sexual minorities experience a 2 to 4-fold greater burden of mental health and substance use conditions when compared with our heterosexual counterparts. And by mental health and substance use, I mean very common things like depression and anxiety, less common, but still obviously very troubling things like suicide attempts, and a variety of substance use outcomes here showing you the statistics for lifetime alcohol dependence. These disparities are even more pronounced if we're talking about trans versus cisgender comparator groups, as Dr. Kia explained earlier. So, and again, thank you, Hannah. Hannah and Sean have really done all of my work here. I probably could have skipped my presentation altogether. These disparities are increasingly interpreted using the theory of minority stress, which was first articulated by psychologist Virginia Brooks in 1981. And what Brooks outlined was a mechanism whereby lesbian women, and now by extension, we have used this model to understand these disparities for sexual and gender minorities broadly. We experience a cultural environment that, to be frank, devalues our identities. It's a cultural environment that, as with a lot of other social isms, social forces, actually creates differences in how we come to understand who we are. And this then in turn creates stressors. That's the stress part of minority stress. And this includes things like discrimination and prejudice and judgment, some of the things that Sean and Hannah have talked about when we get into the healthcare system, how people are taken up and treated as whole people in the healthcare system. But I really more and more these days pay attention to the second pathway that Virginia Brooks pointed to, which was restrictions in how we earn money. A restricted access to economic opportunities. And there's lots and lots of ways that we still have to learn how sexual and gender minority people in Canada are put into particular economic circumstances because of the jobs that are available to them, the jobs that feel safe to them, the jobs that they can maintain, et cetera. So all of this adds up, it accumulates. This diagram that Virginia Brooks drew for us back in the 1980s kind of looks like snowballs to me. And over time, what we see downstream is that all of these stressors accumulate over our life, and they lead to how we, our sense of self-esteem, our sense of security, and eventually create a cumulative load of stress that is associated with a range of biophysical and psychological outcomes that Hannah and Sean have already referenced. So that's the theory. How does this show up materially in the lives of LGBTQ2 people? Well, these are the results from a survey of thousands of high school students in the United States. I don't have a similar example from Canada, but I can tell you based on the research done by Olivier and myself and Sean and Hannah, we see very similar patterns showing up here in Canada. So what you can see on the left are the top 3 cited problems among LGBT youth in high school, or age of high school. And you can see that by the age of 14, our lives are patterned in fundamentally different ways from non-LGBT identified youth. While cisgender and heterosexual youth are thinking about how they're doing in schools, what are their grades like, what's their career gonna look like, LGBT youth are predominantly focusing on how are they going to manage their family, particularly if they're not accepting of their identity. What will interpersonal conflicts look like in school, and can they come out safely? So you could imagine how this really early on shapes how we think about our place in the world. I've spent, as Sean alluded, I spent much of the last 2 years doing research on so-called conversion therapy, which we might think of as the sharpest edge of this minority stress process. Conversion therapy refers to organized and intentional efforts to avoid expressions of lesbian, gay, bisexual, or queer identities and/or gender identities that differ from sex assigned at birth. The health effects of conversion therapy are severe. In a Canadian study that Olivia and I led a few years ago, we found that 1/3 of those who had gone to conversion therapy had attempted suicide. And our best estimate at the moment is that 1 in 10 LGBTQ2 people in Canada have direct experience with conversion therapy. These practices have been made more visible, and I'm thankful for this, through films like Boy Erased and The Miseducation of Cameron Post. But what we're learning is that conversion therapy takes a lot of different forms, and it takes place in a lot of different environments, not only anti-gay Christian camps, but a lot of places. And so we need to expand our view to see conversion therapy as part of a larger set of practices. And this has led our research team to frame conversion therapy as the tip of an iceberg. So beneath it are efforts to discourage LGBTQ2 identities, which may not be as organized as a conversion therapy camp or a clinical program, but they are more frequent and more insidious than these formal conversion therapy programs. We call them sexual orientation and gender identity and expression change efforts, or SOGIs. And of course, all of these practices are made possible by underlying belief systems that privilege cisgender and heterosexual people, just as Virginia Brooks explained 40 years ago. So this means that the kinds of conversion therapy experiences that are getting popularized in films are maybe placed up here. And beneath it, we have things like the practices that we use in schools, in lots of educational and religious and family settings that reinforce very particular binary gender roles that actually slowly but surely lead up to and amount to the same effects as conversion therapy. I really appreciate what Sean shared about residential schools, which in addition to stripping Indigenous people of their cultural traditions, also enforced a colonial binary gender role. So it very much fits in my mind with what we're talking about when we say conversion therapy. I want to talk about just one more kind of form of minority stress or kind of form of social patterning that affects our health. And because we tend to think of those really overt examples like people getting bullied, people experiencing discrimination in the healthcare system, but minority stress also affects us in less overt ways. These are data from the California Health Interview Surveys showing us among aging lesbian, gay, and bisexual adults that this group is at least 50% more likely to be living alone when compared to aging heterosexual adults. And this is at a time when we know that social supports are really critical to managing our health. So this really points for me to this factor of isolation and loneliness. We need to think about, and I really love some of what Hannah is proposing around peer-based interventions that are mindful of how our life course looks different as LGBTQ2 people. How do we account for the ways in which minority stress have affected our social connections? So I also want to offer my thoughts, and I loved hearing from Sean and Hannah what they think we can all be doing in the healthcare system. I think of this in a very conventional public health way as levels of prevention. So whereas most of our healthcare system is preoccupied with what do we do once people are diagnosed with illness, I'm interested in how do we enact secondary forms of prevention. So how do we adapt and tailor? And I love what Sean was sharing about kind of investments in preventive strategies among Indigenous folks in Canada. I think the same could be said for queer and trans people, irrespective of indigeneity. I think we have some really fantastic opportunities, and we've learned a lot from the HIV epidemic in how we can actually implement effective secondary prevention. And here in British Columbia, we've done this through the creation of a database and a website called MindMap BC, where we have found low-cost, free, low-barrier mental health services. We have contacted them to get all their details, and then we've specifically tagged the ones that are LGBTQ2 affirming, just to take away one more barrier for folks looking for mental health supports. And if we go even further upstream, we need to start to get really creative and really aggressive in our public health approaches to reduce minority stress. So I'm heartened that the federal government is interested in preventing conversion therapy. We have a bill that's just passed third reading in the House to outlaw conversion therapy, but we need to do a lot more if we want to actually decrease those expressions of SOGIs in childhood environments. What can you do in addition to the great suggestions that my co-speakers have offered? I would add the following, which are recommendations I made in a piece for the National Collaborating Center for Determinants of Health when I was speaking to public health practitioners. First and foremost, let's find more ways to promote social, supportive and affirming social environments. And this is just one of many places to start. We have a fantastic national advocacy organization called Action Canada, who have written a lot about how we need to revisit our comprehensive sex ed curricula to make them specifically affirming for queer and trans people. But you could also think of many other educational and cultural environments that could be made more supportive. You can work with LGBTQ2 affirming partners, look for your local organizations, PFLAG groups, et cetera. Take the time to learn about LGBTQ2 trauma and stigma. I think we've offered a number of references today that really help people appreciate historical and contemporary forms of trauma and violence that this population is continuing to face. And then collect data. We have so much need for data in lots of different forms of research and evaluation in Canada. And there's some really great advice coming out about how we can integrate sexual and gender diversity measures in these studies. So these are a list of web links, and I realize probably you don't have time to write them down, so feel free to email me or email Olivier if you want to receive any of these. And now I'm very happy to take questions along with Sean and Hannah.
Thank you so much, Travis. and Sean and Hannah for those wonderful presentations, very insightful, and we're very lucky to have you today. So we can do a question. So if you're not shy, you can turn on your camera and you can introduce yourself before your question if you want to. If not, you can also you can actually type your question in the chat box, and I can ask the question for you. I see that Maxime has turned on his camera. Is it because you want to ask a question, Maxime? No? So, well, what about, I just have a question for you, the three of you, that increasingly we're talking about non-binary individuals, and I understand that they can or may not, and they can fall under the trans umbrella, but they remain like extremely invisible in the research agenda, So what do you see as the state of research for non-binary individuals, and what do you and what action do you think we can take as a community to make this population a bit more visible in research?
Maybe I'll start and then others can weigh in. I really think, kind of building on a point I was making in my presentation, we need approaches that help us disaggregate between the experiences of binary trans folks and non-binary folks. I think part of the beauty of many of our trans communities is that we are evolving and that there's new language on the horizon constantly. And so I think these, bringing in more non-binary voices would need to be sort of done in unison with community to find out what language is currently used, so that, we can really reach folks who have diverse lived experiences. Even the term non-binary, for example, might not necessarily capture folks who identify as genderqueer or gender fluid. Some folks who identify as non-binary also identify as trans. Others exclusively identify as non-binary. And all of these are perfectly valid configurations. And so I think really my takeaway message is check in with the community, especially if you are doing locally sensitive research, and find out what language is currently in use, and make sure to tailor whatever research approaches to that language, rather than sort of operating from the scholarship, because we know the scholarship is really slow moving relative to how we see our communities, evolve and move.
Thank you, Hannah. I don't know if Travis and Sean want to add to this question.
So I guess my comment would really be around the focus of scholarship and I'm involved in a number of very large national projects that don't necessarily focus specifically on the LGBT community, and at times what I think can be laziness on behalf of researchers to not want to take up this issue because they see it as too complex, and that really taking and thinking through this data and the data sets that come out of it can be more for them time consuming, energy consuming, et cetera. And so instead we just leave it out. We collect it and we say, oh, all of these kind of notions, we're just not going to deal with that, or we're not going to identify that. And that leaves really rich data that we know has been collected on the wayside, which is so critical to actually uplift people and to understand health. And that, again, that we also see and continue to hear kind of these narratives around, I'm on an aging project, and there was a discussion around whether or not, do we need to use this type of language, because they were like, oh, they're older folks, will they really have this? And that there are a number of us that do kind of sexual work and sexual health, and we're like, no, this is so critically important. We actually see so many older adults reclaiming this and saying, no, I want to, that are kind of in this movement at the forefront of it. And I think that's so important, and that we really do need to be cognizant. of that, and that we continue to drive scholarship and we challenge our colleagues to drive forward really strong scholarship in these missing areas that continue to be neglected.
I don't have much to say, much to add, except to just affirm what Hannah and Sean have both said. And I hope that if you have us back for a CReSP talk in a few years, there will be a whole new body of scholarship on non-binary health.
Sorry, I did have one more thing to add. Just building on something Sean said about, some researchers leaving out data on non-binary folks because, the samples are too small, there's nothing they can do with the data. I think this really draws our attention again to the utility of qualitative methods. We need to explore qualitative methods because they allow us to do something with small data sets. So even if you are doing a quantitative project, maybe having a qualitative aspect to your project in case you do have small cell sizes that you're anticipating for gender minority populations is one example.
I think, Michelle, you had raised your hand. Do you still want to ask a question?
Yes, I do. Actually, I have like 3 questions, but I will go with one. So it's actually to the 3 of you. Thank you so much for the talk. And the question is about the health inequity from countries other than the United States and Canada, and of course from other than the European countries as well. So can we gather data as well from the LGBT communities from other countries, like other than in the United States and Canada, and these data would still be pertinent or applicable like to communities, like for example, in Canada or the United States, especially when there's this sense of community as well? Thank you.
Does one of you want to respond?
Oh, sorry, Hannah, were you going to go?
I was actually going to suggest that you go first, because I imagine you have a really good appreciation of sort of the global context of human rights legislation. That's a lead that I was going to start with, but maybe you can start and I can add on.
Yeah, I wasn't going to say much except because it's not really my area of work. I've mostly focused on Canada and the US, but because I've spent a lot of time in the last year trying to keep tabs on what conversion therapy looks like, which is a really ill-defined kind of set of practices. It has brought up, our sense that conversion therapy is really quite prevalent in many parts of the world. And my colleagues at Outright International have just published a report last year, which I can put in the chat, that has pretty extensive assessment of where a number of countries around the world are at with conversion therapy. I mean, we see really, I think maybe this is where you were going, Hannah, we see kind of 2 categories of responses. There are countries like Canada, Germany, Australia, Malta, which have been basically trying to pick up with where psychologists and psychiatrists and social workers left off in saying we don't allow for conversion therapy, and we're trying to now get rid of it from unlicensed settings. And then there's another set of countries where it is still so difficult for anyone to safely be out that the topic of conversion therapy they can't even address until they had first addressed the issue of human rights protections. And so, I mean, I'll let Hannah say more, because I know you have done some work with immigrant populations here in Canada, Hannah. But I think, yeah, I'll share the Outright report as a contribution.
Thank you, Travis. I actually don't have too much more to share, but I did want to say that, we do have such inconsistencies in access to human rights legislation across the world that I think, we would need to tailor our approach to research accordingly to make sure that we can actually address equity issues appropriately if we are operating in jurisdictions outside of the US, Canada, Europe. And I'm actually not as familiar as maybe I should be with the scholarship in this area, but I do think it kind of merits its own attention. And you know, for me, an entry point into that is kind of engaging with the experiences of newcomers, and in particular asylum seekers in the Canadian context, to see kind of the context that folks bring with them when they arrive in Canada. That's just kind of a starting point as it relates to my program of research. But I absolutely believe in the importance of collecting and analyzing these data worldwide.
Maybe there's two questions in the chat, and there's a Tara that she wants to ask a question as well. So we'll do one in the chat and come back to you, Tara. So Jean-Sébastien is cooking his dinner, so he decided to type his question, which was easier, so we don't get all like hungry seeing what he's cooking. So you can all read the question, I believe, but I'll read it. Of course, stigma, victimization, discrimination, and so on don't distribute equally across all oppressed groups. But I'm curious if any of you study or include relationship modes, so non-monogamous or polyamorous people and polysexual people in the LGBTQ2+ acronym. And specifically for Sean, there is a receiving ID that First Nation used to have polyamorous relationship culturally accepted before colonization. Is it the case?
So I can speak, I guess, to the second part, and then I'll talk a little bit about my former, so I will speak less about kind of the role of research, because none of my research includes any of those specific kind of those pieces that we would be pulling that as data specifically. But certainly, you know, as like when I was leading Pride Toronto, for many years, there are ongoing discussions within, I think, the LGBT community about the use of acronyms, how much and how kind of expansive those become, and what gets included within that definition. But certainly, from an organizational perspective, as we had that, the recognition of people coming to Pride and within the umbrella of the LGBT community was this idea of people who also, you know, were in non-monogamous relationships, polyamorous relationships, poly people overall, like are a foundation to the community as well, and see whether or not they identify as LGBT within that acronym, certainly find a home within within kind of the queer community overall, I think is a lot of what I hear and tend to experience. For people who may say, "Oh, I'm straight, but I partake in you know, other aspects of being kind of a sexual minority within kind of Western society." And then in relation to polyamorous relationships, so yeah, so there have been certainly recorded. There's lots of really interesting. There are some colleagues that do some really interesting work around sexuality at contact of Indigenous peoples, not only in Canada, but around the world. I think that we saw, and there's some research out there that talks about the letters that were sent back to England, to France, to Portugal, to the Roman Catholic Church that depict across the world, whether it be Africa, Australia, New Zealand, North America, that there were very wide-ranging sexual relationships that were taking place. There was widespread gender diversity within at contact, and so certainly there are scholars and there are people that are passed down traditional stories saying that yes, this is indeed the case, and this is the big resurgence of that. We need to move back to traditional understandings of relationships and gender identities.
Thank you. I don't know if Travis or Hannah want to add anything, or no. Tara.
Hi, well, thank you so much for these talks. It was really, really interesting and enlightening. And I guess one thing that really resonated with me is the importance of language. And it's interesting to hear you stress that point, how fast gender identities and identifications are moving across queer communities, non-binary communities, and how how slow it is to get these echoes across to the mental health care resources. And that's something that really came across so far in our research with Olivier on LGBTQ youth 15 to 24 years old consuming cannabis. And one of them who identifies as trans stressed that the doctors wanted to medicate his identity away. So, oh, you're feeling dissociated, you're feeling issues, so pills and pills and pills and pills. And it was interesting, the photo voice that we got from that picture was just a cabinet full of pills and no access to actual, I guess, proper resources, proper therapy led by trans people, led by non-binary people. He also stressed that he would be uncomfortable being with a cis therapist, and how hard it is to find these resources led by people who share awareness, identification, or at least an awareness of these issues, and the importance of having a network that they can refer to, which also, I guess, resonates with the last question, therapists that are poly-friendly, open to other modes of being. So I find that very interesting how I guess it enlightened me a little bit on how slow this transition is from academia to healthcare practitioners. And I guess that's why I think it's very important to work with youth to youth and people, from marginalized communities that can stress the language that they would like to have used within these resources. So I guess I don't really have a question. I just wanted to share that helped me with these reflections. So thank you very much for that.
Thank you so much, Tara. I really, really appreciated hearing your thoughts. And one thing that I also want to add is, I find it really fascinating how language can be very different across different age cohorts as well. So a lot of my scholarship involves older adults. And just to give you one example, a lot of older trans folks actually continue referring to themselves as transsexual exclusively. Yeah. That is the one term that resonates for them. And for a lot of younger trans, non-binary, and gender diverse folks, that is not a term that is reflected in their lived experience. And in fact, many consider it a disparaging term. So I think in our practice, what this all suggests to me is the need to make space for different kinds of expression and how people language their identities. I think it's much harder to translate that into scholarship, but in clinical practice, there's certainly lots of possibilities to do that. Thank you so much. That's an excellent point.
Thank you.
And then there was another question in the chat related to Malek, which I think, we talk about the layering effects of like indigeneity and LGBTQ identity. So I think it was this question is larger than that, was probably sparked by Travis' data on high school students. Like, what do we know about this effect of layering with Black population, Black LGBTQ youth or Black adults?
I'll just say very briefly, and then let Sean and Hannah say more if they'd like. But as Sean explained in introducing the concept of intersectionality, we know that experiences of stigma, minority stress, and context for LGBTQ2 people are not monolithic. There's huge variability across racial and cultural contexts. That study from the Human Rights Campaign did not report data by race, but there's a really amazing growing scholarship in the US and elsewhere from queer and trans scholars of color. I'll just share someone who I was just talking to Olivier about, who's Skylar Jackson, who was formerly at Yale and has done a lot of really amazing work on the intersecting experiences of stigma related to sexuality and racism for Black people in the US. But perhaps Hannah or Sean want to say more based on their work.
Yeah, I think,
or Olivier, you've done work.
Well, yeah, I think, the state of data that we have in Canada on Black LGBTQ folks is really not to the same level than what we have in Canada. And I think, I think we've done a very bad job, I think, researchers, to kind of engage this community, and that, as a result, we haven't been very good at measuring inequities in their experience, specifically in the survey that we have, because often, we do not have enough Black participants. So, I think it doesn't speak because they don't exist, but, they just maybe they just don't see our research as relevant, or a researcher is pushing their issues. I know there's kind of interesting work happening in Toronto, but across the, I would say that it's very deficient overall in Canada. And I think, researchers, should attend a bit better to that issue. Maxim.
Can I just, on that too, that it's really how little scholarship there is to on Muslim queer identities. It's literally non-existent, and it's so important that communities that have very little resources. So yeah, that resonates with that also, yeah.
Yeah, thank you. Yeah. And I think, we've mentioned Black, but I think in general, racialized communities have been kind of under-researched, when we come to racialized LGBTQ population, for sure. And that's not just for Black individuals. Maxim, that will be probably our last question.
So just echoing on the last discussion, I wanted to hear your opinion of what is the place of activism within academia?
I mean, to me, it really is, as a social work scholar in particular, I think of, activism as the purpose of scholarship. I tend to treat my research as a form of social work practice, and social work's value base is really centered on the pursuit of equity and social justice. So that is woven into all of my research to the extent possible. And I think in light of that, I tend to take a very pragmatic approach in my scholarship. I'm not, married to one particular methodology or theoretical tradition. Basically, I'm open to anything as long as the end goal is really guided by a vision of social justice. So to me, it's absolutely central to the academy, even though I know that is that's an opinion that varies in prominence across.
Thank you, Hannah. I don't know if Travis, do you want to answer this as well?
Well, just to agree, I think I really like the way you framed it, Hannah, and I think really the work that we've been doing, and I see Elizabeth Dromer is here, and Olivier, and the work that we've been doing together, and Hannah, the work we've been doing to look at what really is happening around conversion therapy. The entire purpose of that research is to motivate policymakers to do more. We specifically collected data to take to the parliamentarians who are debating the conversion therapy ban, to show them that their ban is not enough and that they need to do more. Yeah, absolutely. I think if for myself, I think yes, of course I have accountabilities to my institution and to my colleagues in the university, but the most important accountabilities are to community members, people with lived experience whose lives are at stake. So if in the case of conversion therapy, if survivors of conversion therapy can't see the value in the research and moving the dial, then we haven't done enough. So that's my take.
Yeah, I agree with what what others have said here. And I think that just taking up a place in the academy is in many ways activism, and that we're seeing the work that we do in and of itself is considered radical. I have colleagues that are like, Sean is too radical. Like, I've had people call out things that I do. I push back fairly hard on the institution overall, but the scholarship that I choose to undertake, while I think is rooted in community and very strong community engaged based work, is in of itself radical to the institution, and in ways we drive forward with kind of policy and structural changes and those types of things that all have a place that continue on the end. So some of the elders I've worked with have said, you know, we drive forward in community, and we have scholars that are now driving forward in meetings and in spaces that we don't have access to, so you can continue that work at those levels. So that would be kind of a bit of my take on it.
Thanks. There's 4 minutes, and I see that Michelle raised his hand again. So that will be the last question. So.
Okay. I believe Liz as well. I mean, as you wish. Well, it's about the behavior, you know, at a young age. Like, for example, if I choose pink instead of blue, is it like a behavior? And let's say my dad or my mom comes over, or whichever parent comes over and tells me like, no, you should play with something that is blue. Is it like a behavior that we should kind of have a policy to kind of control or mitigate, like in order to kind of avoid any risks on the mental health of the child? Not just the blue and the, you know, the pink, it's also the doll, playing with a doll or with a car.
Well, that's a big question for 3 minutes. I don't know about policy, but my sense from the people that we've talked to who've struggled with those kind of SOGIES related nudges, do this and not that, is that parents are afraid for their children. They may not have direct experience with gender and sexual diversity. Maybe they came up in a time and a place where that wasn't presented as a viable option to them. And so they're acting out of a fear. And so I don't know that policy can remove fear, but I think probably there are educational approaches and social supports and peer-based supports that could actually help those parents understand why their fears are at least partially unfounded, and that the alternative path forward is actually affirming their child's choices. I don't know, Hannah or Sean, do you disagree or have something to?
No, I was just gonna mention that I think for me, it's more a question of normative and cultural change, and you know, making more opportunities for education and affirmation available to parents. And coming from, you know, a racialized newcomer family, you know, I think one of the things that was most helpful personally was for my mother and others to be exposed to community resources and understand what it would mean to affirm their child. And I think those kinds of opportunities just need to be made a lot more available.
Thank you. Well, now we are at time. Thank you everyone who attended, and thanks for the CReSP for hosting us. And thank you so much to our presenters, Hannah, Sean, and Travis. Thank you so much. This was a very good discussion, and hopefully this is not the end of LGBTQ2S plus content produced by CReSP, and hopefully we'll see much more of that. Thank you so much.
Hi Travis, hi Hannah.